Welcome back, everybody, to the ASAP Pathway podcast. I'm your host today, Dr. Stacy, and Dr. Tracey is here with us as well. I love when
Hi,
she's on with
everybody.
me. Love when she's on with me. And we are doing a part two today, so I'm really excited about it. Dr. Doug Young is back with us, and we didn't get to everything we wanted to talk about in the part one. So I promised all the listeners we'd have you back for part two. And for those of you who want to listen to the bio, the intro, and the whole episode, it's episode 36. But today we're going to get to some topics we didn't get to. Um, and he's just an amazing expert in minimally invasive dentistry and utilizing things differently than what's being taught traditionally in dental schools to preserve tooth structure, to basically eradicate decay. And that's how this disease is still around is kind of crazy.
Mhm.
Yeah. So thanks for
Um,
having me, you guys.
Absolutely. I'm glad you came back for a part two. Um, let's just jump in with I kind of want to jump in. The title is going to be minimally invasive dentistry. What does that mean for a patient when they hear minimally invasive dentistry? What does that even mean? What's that mean to you? And how can we help patients understand and how to find this?
Yeah, that's a funny question because we come up with all these dental terms and jargons, and everyone wants to create their own new term for things. So, I look at the big picture, the big umbrella, is we're treating disease. Just like you guys are so advanced in airway, it's all boils down to what's the root cause of the patient's problem, right? So in the last podcast, we got to talk about treating the disease at the patient level. Um, Minimally invasive dentistry to me is treating the disease at the tooth level. And how do we do that um, with the least minimally invasive way possible, which is to eliminate and reverse and prevent the disease in the first place. So it starts at the patient level, and then you use the same chemistry that we've learned to treat caries at the person level, and we treat it using chemistry at the tooth level. So that's what minimally invasive dentistry is to me.
You're right. There's a lot of people using different terms to describe different things in dentistry. You'll hear airway dentistry or airway minded orthodontics. I mean, we've got different terms kind of flying all over the place. So thanks for explaining that. Um, let's jump into kind of a topic that we didn't get to, kind of piggybacking off of fluoride. We had a discussion about fluoride. We had a discussion about the protocol, uh, basically like baking a cookie. There's a recipe for baking a cookie, and there's a recipe that you can follow that basically eradicates decay, tooth decay. And if you follow that recipe, you can really take your own oral health in control of yourself and grab your autonomy and not act like cavities just happen to you and you're a victim. You really can take control and minimize this in your life and your family's lives. But we got on the topic of fluoride because it was kind of that piece of that recipe. And I had asked you, there are people that just don't want fluoride. And you said, you can still do the recipe, but it might be they have to be more diligent or it's a little harder to do. Um, is there a substitute that you would put in that recipe? Like Tracy and I were talking before we got on, like hydroxyapatite or something like that. Could you replace the fluoride with something else in that paradigm?
Yeah, and I think you hit the nail on the head. A lot of these dental manufacturers are starting to make non-fluoride products now. And I don't know if it's because of the political environment or people just don't want fluoride in the water anymore. I don't know. As you know, fluoride's our number one weapon against dental caries. It's got the most research on it. Yet, if people don't want it, then you gotta find out a different way. So, how does nature handle it? Saliva, right? Saliva has what? Calcium phosphate, pH neutralization, and excuse me, if you control the biofilm and reduce the biologic acids, then really you doing everything you can to prevent disease. So what are new products out there? Products that combine pH neutralization, some kind of source of saliva supplementation, I'm going to call it, and I'll explain that in a minute. Um, Things like calcium phosphate and the pH neutralization are mimicking or helping people that don't have enough saliva to perform, the duties that healthy people have that don't get cavities, right? So there's antibacterial products out there that are trying to modify the biofilm to be more or less acidogenic uh, and acidic. Um, but one of the ingenious ways to do that is using the pH itself, because acidogenic organisms, by their nature, are designed to live in a pH range of 3.8 to 4.8. And so if you raise the pH to 7, they just don't have the mechanisms to cope with that environment. So you're kind of encouraging the good bacteria to grow, and you're discouraging the bad bacteria. And so those are just ways that you might look when you look at dental products to see what ingredients they have and see if those are helpful.
Are there some products out there for people listening that change alter the pH and increase saliva flow that they could get over the counter or
Yeah, are we allowed to talk about products on your
Absolutely.
podcast?
Just
All
I
right.
always clarify, look, when we talk about a product on here, it's patient education. They need to do their own research. We're not promoting a specific company. So just making people aware of what's out there and then they can decide for themselves.
Yeah, I mean, every major dental manufacturer is going to have dental products for caries, right? And the big ones are, already on to remineralization. You can see TV ads on it. But some of the smaller companies, and I'm going to give you full disclosure, um, Carie Free, have you heard of those products?
Yes, yes.
I have financial relationships with Carie Free. Their CEO is my best friend, Kim Cooch, and Tracey, you've done podcasts with him.
I love
And,
Kim.
and he asked me to help him develop products for Caries disease. So probably 2 decades ago, he took the ball when no one else was willing to listen to my recipe. So his products are designed uniquely to combine the 5 ingredients that I gave you earlier. Calcium phosphate, pH neutralization, fluoride for the fluoride product line, and nanohydroxyapatite for the non-fluoride line. So you try to mimic the recipe without using the fluoride. They have antibacterial products based on a 0.2% hypochlorite mouth rinse, and the pH of that is high, so it is kind of giving you a two-prong approach. Not only kill the bad weeds in the lawn, but give it fertilizer so that the bad weeds can't grow and the good grass will grow. And so if you look at the Carry-Free product line, I think they're pretty unique at combining that strategy into the multiple products, because the last issue is how do you provide that for someone that doesn't have good saliva 24/7,
Mm,
right? You
right.
just can't take a toothpaste and use it 2 minutes in the morning, 2 minutes at night, and that's 4 minutes of treatment. And then the rest of the day, their teeth are dissolving. So you need overlapping products um, during the day. Fun things for kids to do use, like xylitol gum, lollipops, things like that, to help stimulate saliva and provide a non-cariogenic treat for the kids.
I have a lot of dentists that have asked just, how to even get trained and how to learn these things. And that's something you and I and Tracy were talking about before we started recording too, is, patients are listening to this and like, I want this. I want this type of, care. I want this for my family. I want this for myself. Um, And in fairness to most dentists, we had I'm Dr. Alan Reisinger on recently, and I'm like, what takes medicine so dang long to, we know that there's information, it's helpful, whether it's cardiovascular disease and the role of dentistry, and we know we need dentists in this battle between cardiovascular disease and oral bacteria. And he said, really, it's kind of like instead of a speedboat, it's more like a cruise ship. So, I mean, it takes, you want to turn, you got to do it like hours ahead. So, we know this really isn't being fully taught in most dental school. I mean, I was never taught this protocol. Um, are there, if dentists are listening or patients, like, hey, have you ever taken these courses? This is something I was interested in, just to like raise a conversation and awareness between patients and dentists. What are some ways? I mean, because like you said, the ADA has recognized this protocol. Is that correct? They have published this protocol.
Well, they came out with two caries management guidelines so far. They had Plan 3, but I don't know if the third one is coming out. The first one was on non-fluoride, or I'm sorry, non-surgical uh, caries management guidelines, and that's where the silver diamine fluoride was highlighted as one option in that toolbox, right? The second one was on restorative. I think it was in 2023, it just came out on restorative. And the two big highlights that I took from that was selective caries removal should be the standard of care. Oh, I shouldn't use that word, standard of care. Should be best practice, or it has a high level of evidence um, that selective caries removal is better or preferred over complete caries removal.
Okay, will you describe what selective caries removal is? Because
Well,
what does that even mean to people
that
listening?
that means if you look at how we treat disease with the traditional drill and fill model, dental students are trained to drill until it's hard. Remember that?
Yeah.
And even going back to when I was in dental school, you can't even have stain in the teeth at the DEJ. So if there's any brown stain at the DEJ, you flunk the board. Now, at least the reps, they've changed that. You can have stain as long as it's hard. But hard is really the sign that the tooth has been already remineralized and is healthy, right?
Right. Right.
But if you go and take away the soft dentin, how's it ever going to get remineralized and become hard? And if you do the research, remineralized enamel or dentin is actually stronger and carries more caries resistant than it was before. So why would you remove something that is 10 times more caries resistant and drill it away, right? So they want you to, the standard of care should be remove what you need to restore the tooth and keep the tooth from having more decay, right? So with the advent of, and we're going to talk about new products in a minute, but let's just talk about old products, whether you, and that was one of the takeaways from the restorative guideline was glass ionomer is no longer a bad word. Glass ionomer is one of the three restorative materials, composite, amalgam, glass ionomer. There's a place for all three materials according to the ADA guidelines. So you're free to use whatever material you want to use. So I first have a personal bias to treat caries with the chemistry, and glass ionomer is the only one that has the chemistry to do that. So I exclusively use glass ionomer with caries. But get back to your selective removal. I'm sorry for wandering.
No, this is
Get back to your
look, these little trails off are educational. So I love it. So go
Okay.
ahead.
So
Go ahead.
selective caries removal is clean the perimeter of the lesion and then maybe go 1 millimeter past the DEJ into the dentin, to make sure you got a clean surface. I call that the 2 millimeter rule. I learned that from my mentor, Dr. He and No from Australia. And that's all you got to do. So what does that do? It gives you a hermetic seal around the lesion. And so now you put in a material like glass ionomer that chemically bonds and creates an acid-resistant fluoroapatite surface at that junction between the tooth and the tooth material. And you got a material that will never leak at the margins, that is acid resistant, and will just get harder with time. Okay, so what's complete caries removal? Well, you go past that DEJ 1 millimeter rule and you start digging until it's hard, right? And if you know anything about demineralization, even a white spot lesion will cause softening of the dentin if the acid reaches the DEJ. And that could go all the way to the pulp by following the dentinal tubules. So, excuse me, a lot of times at the state board, people get pulp exposures. So they had to come up with a rule. Well, you could stop if you see blushing of the pulp. If you're within half a millimeter of the pulp, you can stop and you could still pass the bores. Well, those cases end up needing root canals because you've overtreated that tooth. You've surgically removed more than you need to do to make that tooth healthy. So in 2023, the ADA guidelines did extensive research on all the systematic reviews on caries removal, and they came up with two things. Either no caries removal at all using silver diamine fluoride, something like that, or some people's mouths will have natural arrest of the lesion, and if the lesion is already arrested, why do you need to drill it? So that's one theory. And then the other one is selective caries removal. Just clean the outside part of the margins, leave the deeper areas. You can even leave bacteria in there. And what you're doing is you're sealing off the, the bacteria, the nutrient source, the sugars, the carbohydrates from getting to the bacteria. So if the bacteria can't have any carbohydrate source, they cannot produce acid. And if there's no acid, there's no demineralization, the lesion will arrest and problem solved. So even a soft lesion will get firm underneath. There's many clinical trials like the famous Mertz-Fairhurst trial that over 10 years they left infected dentin into the tooth, the mushy, soft, bacterial infected layer. They left that in the teeth and 10 years later, it was rock hard. There was no problem.
So
As
that
So,
long as
leathery, soft stuff we
yeah.
were taught to scoop out and get rid of,
So
leave.
I think, I think it's important, because like our audience is patients and dentists and, what we're taught in dental school. And I think it's important to talk about um, patient consent and being informed consent. Like I know you're saying leave some of the decay, but there's also, I think we have to talk about some of the risk in leaving some of the decay based on the evidence, because it's not standard of care right now in the dental schools
It is
to leave
not.
some decay. So I think that's very
Well, it
important.
should be.
Mm.
I'm not arguing with you with that, Doug, but I'm also at the same time not. I'm not encouraging patients to go tell their dentist like you need to leave some of the decay, because like ASAP, we try not to be in the middle. Like you still should consult your dentist about your current situation. Um, Now, let's talk a little bit about the risk of leaving it, because obviously you're talking about the benefits of it, but there's also a risk in leaving it, and hence why it's not the standard of care in dental schools. So, can you talk a little bit about that too? So, I think that if we're going to advocate for something, just informed consent, why do some dentists not do that? And so we can understand that better. And which kind of, like if we're going to leave, and I will say in my practice, why I leave it is if I know if I go chasing it, I'm going to have a pulp exposure.
Yes, right.
That's for me. Yeah, that's my number one. I'm gonna have a pulp exposure, and I will tell the patient, I'm kissing the nerve right now. If I go digging anymore, we're gonna have a pulp exposure, and most likely you will need a root canal. Now, what's the probability, like based on the literature, the percentage of leaving decay there and the chances of needing a root canal?
That's a good question, Tracy. And I'm gonna try to be as gentle as I can because I understand.
I know, like I'm just trying to play like devil's advocate and I don't want,
Because I've gone through it. I
right, right.
Right.
back when I was in my young days in practicing, people accused me of leaving caries in the teeth. And this is the fear that dentists are still, and this is like 3 decades ago, and this is the fear that's still being propagated out there by dentists. They don't want to be called out by the local dental society,
Right.
ethics board. They don't want any complaints of the dentist next door when they look at an X-ray and they see a radiolucency underneath my glass ionomer. Because if you leave that leathery remineralized area, even though it's caries protected, it's going to look like a radiolucency on an X-ray. If you understand what
Yeah,
X-rays do, they just show a contrast between uh, mineralized, more mineral changes, mineral density changes. So the dentin, because it's 50% mineral and 50% water, and diffusion channels, then it's never going to show remineralization on an X-ray. That's why when you use something like silver diamine fluoride, you can see the radiographic radiolucency almost disappear most of the time on the enamel, but you will never see it disappear in the dentin.
hmm,
So when you use new science, you have to really think it through. So I want to get back to your question because it's critical people understand this. The highest level of evidence are the ADA clinical guidelines, right? They are more than randomized clinical trials, they're more than systematic reviews. They spend a ton of money looking at the breadth of research around the world, different languages, um, and the 2023 clinical guidelines on restorative clearly stated there's no reason to, to remove the bacteria in a lesion to get to stop the problem, right? Because think about it. Even if you drill till it's hard and you restore it, there's tons of bacteria in that underneath that restoration. I
yeah,
think Rella Christensen was the most famous about her studies showing that we don't work in a sterile environment. You're going to find bacteria underneath every restoration if you look hard enough, right? So when the research, the literature looked at the science behind it, it's not the bacteria, caries bacteria are, it's not cancer. If you leave a cell of cancer, that might be bad. But leaving bacteria, you just have to keep the bacteria from creating acid. And the way to do that is to cut off the nutrient source. That's the science.
Yeah.
And so
Starve it.
drilling till it's hard is going to do nothing. It's just going to cause more pulpal decay. And you dive deeper into the selective caries removal world, there's things called stepwise removal that preceded selective caries removal. And what stepwise removal is for people that didn't want to leave any decay, quote, decay, I don't use that word decay or caries, but if they wanted to leave infected dentin, they would first remove the outer layer, seal the tooth up, prevent it from having a nutrient source, then go back and re-enter the tooth and remove that layer underneath that they and they found, okay, now it's harder, so I don't have to go as deep. Just what you were saying, Tracy.
Mhm.
But in the end result, that just caused more deeper penetration to the pulp. And the closer you get to the pulp surgically, the more chance that that tooth is going to need a root canal. So a lot of the research showed that stepwise is not really necessary. And I know there's controversies. There's some studies that show, you know, it doesn't. But if you get good results with selective, why would you need a two-step procedure and go in there twice and cause the patient more money and more chance of pulpal damage?
Yeah, I
And
mean, yeah, I mean, I definitely agree with you. A lot of times, like when I see caries on an X-ray, and I tell the patient, I was like, okay, like it looks pretty bad on this X-ray, and I'm probably gonna be in the pulp, but let's, this is where we're going to be. And I think it's good to have like full disclosure with the patient because, the patient can go to another dentist and be like, oh, they
Yes.
left decay, and then that's where. So if I'm understanding you correctly, and this is just, pretty much for our audience, that it's case based, obviously. We're not, and it's something that you have to have a discussion with your dentist. That if the decision is to leave decay, the reason is to leave decay is you're reducing the risk of pulpal exposure. And it's not a taboo procedure to leave decay. And obviously, it's very dependent, case based dependent, and it's something that you should consult with your dentist on.
I think you're being very conservative,
Yeah, I
Tracy.
think so
I
too.
I think you're being very safe. I think you're I think that is a wise approach for people to take. But I'm going to stand hard and say that's not what standard of care is saying now. Standard of
Yeah.
care is saying no, you don't. You don't need to have a discussion with your patient. You might tell them that things are new and show
Mhm.
them the new guidelines and maybe help them understand that nothing we do in the mouth is sterile. Um, but I don't think I don't think we need to be worried from a scientific basis. Now, I understand what you're doing from a cover your rear end.
Right. To
And
go
that's
when they go
probably
to the next dentist so they understand, look, patient,
exactly.
you are, if you ever go to another dentist that doesn't practice the current, current guidelines
But
that
I
the
use that as marketing. I
yeah.
use that as a practice builder, right?
Yeah.
Who would want to go to somewhere else that's going to, you know, drill more when they don't need to? So, yeah, use it as a practice builder. Turn it around. I did want to mention one thing you said about X-rays. X-rays don't show caries. X-rays show changes in mineral density. So
Hmm,
think of it as demineralization. So I don't call radiographic caries. I call it's a radiolucency. It's something we're looking at on a two-dimensional object to try to represent a three-dimensional problem.
Mhm.
So even though it appears that the radiolucency is close to a pulp horn, in two dimensions, it could be clearly
sure.
away from that. So we have to be very careful not to diagnose endo or endodontic treatment from a radiograph alone. You got to go by vitality testing. And so, that's another thing, a pet peeve of mine is right now we are in an epidemic of overtreatment. We're treating non-cavitated white spot lesions, right? Uh, and we're treating it with surgery. And unfortunately, I'm going to jump to the source of the problem. It's the reimbursement system we have in the US. We don't get paid unless we drill a tooth. And that's got to change. And if it doesn't change, um, I think Stacy, you mentioned it. We need to educate directly to the public because when the patients come to the office and know more than or not more, no more, but know what they want more than the dentist, um, it's going to drive what practice does.
It really is patient education, which is what this whole podcast is trying to do in this episode. And I can appreciate what Tracy's, she's always trying to be super safe with the podcast. But I just to reiterate, like let's logically discuss that. Like with the bacteria, just because we can tap on a tooth with a Shepherd Hook Explorer and it's hard, doesn't mean there's not bacteria in there, folks. We didn't sterilize the tooth because it's hard. So we know bacteria is left behind. So,
Well, let me cover one more thing because this is very important too. Bacteria, because of the physical size, cannot fit through enamel pores. The enamel pores in between the enamel crystals and rods are called diffusion channels, and they're very, very microscopically small. So if you took a bacteria like, the plaque we see on the outside of the enamel, if they were able to get through the enamel, we'd be in big trouble, right?
yeah.
So the enamel is our protection from getting infected dentin, right? So if you look at the ADA caries classification chart that I didn't get to talk about, um, it came out with a system to grade the lesion progression on a tooth from A to Z, from point outer part of the enamel to the dentin. And so there's no bacteria if the tooth is covered with enamel, even if the enamel is partially cavitated. So if you take a white spot lesion and you let it progress, that smooth white spot lesion on the surface will eventually get rough on the surface and actually start to get little, I call them potholes or, missing enamel. Those are microcavitated lesions. And even though there's the surface is dissolved, the underneath layer of enamel is protecting bacteria from getting a tooth. So according to the ADA caries classification chart, when should you surgically restore a tooth is only one scenario. When it's fully cavitated and the enamel is totally missing, there's a hole from the outside all the way to the dentin. Otherwise, you could treat it with minimally invasive dentistry, starting with remineralization and using new techniques we didn't even get to talk about yet to preserve the tooth from getting a full-blown restoration.
Well, I think too, we're in an era where patients are probably more about advocacy for their own health and doing their own research just because we have all the platforms for education out there. We've got podcasts, YouTube, people are more connected, aware, having conversations. So I think that's excellent. And like you said, it could be a practice building tool. It is what makes you different, just like airway. Not every dentist is screening for airway, which we would love for that to change. And the ADA has made that very clear that that should be part of your scope of practice is screening adults and children for sleep and breathing issues. So it has to start somewhere. Um, and it is just about having those conversations. And I do think now more than ever, patients are open to having these conversations. And it's really just, about, hey, this is how we do things in our practice. And I think if you have the literature and reasoning behind that, the patient can then make a decision and just educate them. Look, just so you know, you're going to have a radiolucency under this filling. And another dentist someday, if they see it, they may say, "Oh, you have a cavity,"
Yeah.
and have that conversation and let it be the patient's choice. I'd venture to say most people would be like, "Well, what's the harm in just monitoring
But,
that X-ray, right?" And
but think about, I'm going to be a real jerk today, but think about what you just said. Think about what you just said. Why should patients be at risk in going to one practice that's going to treat you one way and going to another practice that's going to treat you a different way? And I'll use airway as a perfect example because you know darn well why would a patient go to a practice other than one that you guys practice that will screen properly for airway, that know what to do and know the ramifications to oral systemic health from having a good airway, not only heart health, brain health, and overall health. Why would a patient go somewhere else once they know that there's a better way to do it? So think of even medicine. I had to go, I live in Oregon, I had to go to Washington to find a doctor that would treat my atherosclerosis the way I wanted to be treated, which is eliminate the cause. Don't just give me a statin, right?
Yeah.
Don't tell me to exercise. To find out why genetically I have atherosclerosis. My whole family has it, right? So I think dentistry needs to do the same thing. It There shouldn't be drill and fill dentists and dentists that treat disease. All dentists should treat disease. And again, it comes down to if you're $500,000 in debt coming out of dental school and you only get paid to drill teeth, what are you going to do? I'm not blaming the dentist. I'm just saying there's a, a disconnect here.
There is. And Tracy, I know, has got a question and about fluoride, but I just want to segue off that before we go to that topic. What is being done I know they're creating ADA codes for more proactive procedures versus the typical drill and fill, who is advocating for this?
You cracked a big nutshell that I'm not an expert on. I can give you my experience volunteering at the ADA, but the ADA is there not to tell people how to practice.
Right.
They're there to help their members, right?
Correct.
So so they're not the ones that could dictate how insurance companies pay you or what they should be paid for. So let's not blame everything on the ADA, but um, I'm sorry, rephrase that question so I
Well,
could.
I mean, and the insurance companies do follow the ADA codes. I mean, it starts with the ADA saying, hey, there should be a code for this, there should be a code for that. And then the insurance companies start saying, are we going to pay for something like that? And what's the reimbursement going to be? So the ADA, albeit they're not telling us how to practice, but they are leaders
Right.
and they
And
are,
if you don't have a code, you can't get
you
paid.
can't get paid.
So think of medicine, right? We need diagnostic codes. If we don't have diagnostic codes and we just have treatment procedure codes, we're in the drill, bill, and fill type of medicine versus preventive medicine and medicine. If you have you smoke, you're overweight, you have high cholesterol, whatever, you get paid to screen for those risk factors. You get paid to treat those risk factors. But for caries disease, we don't get paid to screen for them. We don't get paid for caries risk assessment. We don't get paid for treating at the patient level. We don't get paid for prevention properly. So there's also disconnect and it's the way we're getting paid. So new insurance companies know about this and they are actively looking for different ways. Like I just had a senior moment. What am I trying to think about?
Well, I mean, what I was wondering is how do we get this rolling? And is there,
Value-based care.
yeah, okay,
Value-based care
yay,
is
okay.
we've heard of this term in medicine, and in dentistry, it's the right model. Um, However, people relate it to things like capitation, which is when it first rolled out was a bad word, right? But if you think about it, capitation in theory is what we really want. We want to see patients and we want to get paid to make them healthy. We don't want to get paid by how many holes can we put in their teeth, right? So value-based care is somewhere a redefinition of capitation. It's how do we get paid to make people healthier? And so that's the hope of the future. Organizations like tribal organizations and FQHCs who get paid differently are highly uh, interested in caries disease prevention and treatment the way we talked about in these two podcasts.
Yeah, they have a totally different perspective of trying to get to the bottom of this than some other communities might be.
They
You're
get
right.
paid on encounter based a lot, and tribal organizations, the dental therapists and the dentists treating them are from their own community. So they
Right.
care about the people they're treating. And
Yeah,
so, it's a whole different ball game.
it's so true. Trace, what's your question about fluoride?
So, I think this is more of like a public awareness. Obviously, there are different levels of fluoride, different concentrations of fluoride. And, obviously, what's going on right now is the discussion of eliminating it in our waters. Can you talk to the public a little bit about understanding the various concentrations of fluoride and why we use it for certain procedures? Because I think, you know, because the mass media is putting a label on fluoride and it's not, but it's not for all fluorides. I mean, I understand the need to regulate the fluoride in the waters, but let's talk about the fluoride that you have that we use for caries risk, the topical fluorides, the varnishes, the benefits of those, and the I guess is it really being delivered systemically and what the literature is saying. So just so the public can be a little bit more educated. So obviously when we were using glass ionomers, it has some fluoride in it. It's not the same fluoride concentration that we're getting in the waters. So if you can comment a little bit about that, just to give patients at ease about what the doctors are using in their treatment.
Yeah, and I think dentistry's got it right most of the time with fluoride. The ADA is very clear on that. Fluoride is safe in the dental products that we use. Fluoride is safe in the water as at a concentration of zero point 0.7 now is the parts per million is the gold the best practice for systemic water. I'm sorry, not systemic. That's a point I want to make. When you put zero point 0.7 parts per million in water and you drink the water, it actually works topically more than it works systemically. Um, Systemic fluoride is when the tooth is developing. You know that as a pediatric
Mhm.
dentist. So after the tooth is formed, swallowing water has really no benefits, right? So why do we put it in water? It's a way to give topical fluoride for large populations that maybe can't even afford fluoride products like fluoride toothpaste, right? So the topical action of fluoride is by far more beneficial than the systemic um, ramifications of fluoride when the tooth is developing. Excuse me. Um, so there's different concentrations of fluoride that work topically. And as long as you don't swallow them, they're going to be safe, right? So why do we need larger concentrations of fluoride? Well, the larger concentration of fluoride will give you a longer time release period. So a 0.05% fluoride or parts per million fluoride in an over-the-counter mouth rinse might last, during the day and you rinse at night twice a day. It might work topically that way. 1,000 parts per million of fluoride in a toothpaste will time release all day and then all day at night. So you're getting topical fluoride pretty much 24/7 if you're using 1,000 parts per million fluoride. And then people that don't brush their teeth or don't use a higher 1,000 parts per million fluoride toothpaste might need a fluoride varnish, which has way more. It has 22,000 parts per million of fluoride. And that time release for months, right? A couple of months. And
Mhm.
so it's a way to deliver fluoride longer.
Um, Sorry, I didn't know if you were still talking. I saw you were
It's
coughing.
nothing.
I muted because I have
Okay,
allergies.
I'm sorry.
We're
Yeah.
having our grass pollen season here in
Oh,
Oregon, and
yeah.
Yeah.
I have terrible hay fever.
It's really bad here in St. Louis too. Everybody's coughing and sneezing and watery eyes, but it's going to bring some nicer weather too, so it's kind of bittersweet. But um, and I'm just going to throw this out here, and I don't want to drag us out too long. But we're talking about all these topical. Okay, so we have systemic fluoride, we have topical fluoride. Well, then we had Dr. Nathan Bryan on not too long ago, who is this nitric oxide expert. And he is talking about even just topical fluoride, the presence of fluoride in the mouth, decreasing nitric oxide production, which affects your microbiome in your mouth. And it can also affect, down the road, cardiovascular disease and stuff like that. So it's, not to throw another monkey wrench in, and kind of get people even more confused, but this is what we are. This is the information that's out there. This is the information that we're talking about. And you have to take this information and you have to do what's best for your family. And like we said earlier, you can have all these amazing things and change all these things in your life and still, you can do minimally invasive dentistry. You can use different products that don't contain fluoride if it's something that really bothers you and you're like, there's just too many questions I have around fluoride. That's okay. There's alternatives. And then we have, like you said, the ADA says it's safe. But there's other information coming out. Well, it may be safe from this, but is it down the road affecting nitric oxide production, which can be causing other issues? So everyone needs to take the information that they're getting, and I think it's a beautiful thing. All
And
this different,
that's where I evolved and I've changed. Even though I do still think fluoride is one of our best tools in our toolbox, it's not for everybody. It's
right?
like you said it, pick your poison, literally,
Right?
right? Right? Pick your
Literally.
poison. So I believe now that we should really listen to our patients and ask them what they want, right?
Yeah.
What's their problem they're trying to solve, and what is the best way to do that with you? And so I'm totally open to non-fluoride products now, right?
Yeah. And we're all changing. Like I don't practice. Tracy and I don't practice the same way
Mhm.
we did 2 years ago. I mean, shoot, even last year. And it's just about having conversations and being a partner with your patient in their care and listening to them. Instead of us putting maybe a ideology or creed or something on them, like how do we maybe meet in the middle and get them the care
Right.
they deserve? And well, we appreciate you being on for this part two, and this was juicy. I
Can
really
I
like.
can I quickly mention a couple
Yeah.
of things because we got sidetracked on fluoride, and I didn't get to finish the minimally invasive part. There's some exciting things at the tooth level.
Okay.
So I'm just going to throw out some names, and you guys do some homework. There's products out there that are focusing on early detection. I'm not going to mention them because there's a ton of them that are marketing that, I can identify a lesion earlier. And that's great if you use it to remineralize the lesion, not to drill it. Okay, so that's one caution. Early detection is great if you treat it chemically unless it's cavitated, but by then you don't need early detection, right? The
Mhm.
other products are more chemical. They're less expensive. They're things like Blue Check. Blue Check is a caries detection dye. I'll classify it as that, but really it detects a active lesion, not an inactive lesion, because and that's something new. There's something called Papa Carry Duo that's been available in other countries for years and years. Just now brought into the US by Elevate Oral Care in January. And Papa Carry's Duo, although it's a funny name because it originates from the papaya, is an enzymatic proteolytic caries dissolution product where you can remove a infected dentin and leave the leathery affected dentin that Tracy talked about earlier. So you painted in a lesion and you let it sit there a minute, and then you could do a light scrape, or you could just rinse it out if you're not allowed to use a hand instrument, because there's no reason why a hygienist can't use it, right? Because you're not instrumenting a tooth.
Right.
So combining these things with SDF and glass ionomer, and you could almost have for children a no drill, no shot practice. And what a better way to get a young patient, interested in their oral health by not hurting them, right? And then why not for adults, right?
Right.
So minimally invasive dentistry, the door is open. We just have to crack it open and look further. There's things out there that I think are worth doing for everybody.
I love that. What a great way to end it. I love
Yeah.
it. I mean, shoot, people think dentists really love to get in there and do all this stuff. I mean, nothing would make me happier than not have to numb somebody up and get in there and remove tooth structure. I mean, that really
And
would
who
make everyone happy.
and who says patients don't want to pay for that? I
Right.
mean, I had to go to Washington and fly up there and pay cash money because they didn't accept insurance to get medical treatment that I wanted, right?
Yeah. It's
Mhm.
really about just putting it out there for the patient, giving them options and let them decide and go from there. Well, you know me, Doug. I got to ask my three random questions that have nothing to do with anything, really.
Oh no, those
Hey,
are the hardest
uh,
ones.
last time it was so funny because I went back and I think I asked you what the last song you listened to was, and you're like, I have no idea. So, but I found out you liked Motown and stuff like that. So that was fun. Okay, first, what is the one thing that you can't live without?
Oh God, I would. It depends what you're talking about. Are you talking about food? It's chocolate, right? Gotta
Okay,
have
if it's
chocolate.
food, it's chocolate. Okay, perfect.
If it's recreation, I'm a hunter and fisherman, outdoorsman, all the way.
Ah,
Can't do without that. But every day, spiritually,
yeah,
I can't do without God.
there you go. I love
I
that.
love God.
All right. And that could have been three answers right there, but I'm not letting you off the hook. You got two more.
Oh
Okay.
no,
Are you summer or winter?
summer,
Okay.
definitely.
See, I threw your
I
softball. I threw your softball. And then I, I can't wait to hear this one. Okay. What's the weirdest talent that you have?
Oh God. Well, if I were younger, I'd say I used to be a gymnast. Uh,
Really?
talent. Maybe I'm talentless. I don't know. I can't. I can't sing. I can't dance. Uh, I can hunt and
I can't do
fish.
those either.
I can hunt and
Yeah.
fish. I'm a good marksman.
Oh, well, that's good. Okay. Good deal. I'll take it. Well,
All
thank you,
right.
Doug. We appreciate
Thank you
you
so
so
much,
much.
Doug.
And we hope,
Thank you, guys.
yeah, absolutely. We hope we answer some questions for people, and we'll put the links for how people can get in contact further with you or maybe book you to lecture to some local study clubs, et cetera, to educate their communities. And for those of you interested in what ASAP Pathway is doing, we'll have a link for you to jump on and join our newsletter and learn what we're doing. Thanks, everybody, for joining us today.
Awesome. Thank you
Thanks.
guys for changing the world. You guys are great.
Thank you.
Thanks.
Bye.
Bye,
Bye
everybody.
bye.